Good afternoon, everyone. Thank you very much for joining us. I'm just going to do a short introduction because we are recording this message, and then it's always nice to be able to know who's who and where we're from when we look at this afterwards. My name is Rika Preiser. I'm at the Center for Complex Systems in Transition at Stellenbosch University in South Africa. We're an interdisciplinary research center that think about complexity and use complexity thinking and resilience thinking to inform our practices in the various fields in which we are working. And today we are very fortunate to have two experts with us from different ends of the world, Professor Joachim Sturmberg and Dr. Bruno Kissling. And Joachim is from Australia and Bruno from Switzerland. And they are both experts in the field of using complexity thinking or systems thinking respectively in their field of global healthcare. Today we will just be reflecting in a kind of an informal way and in a conversational style about how complexity thinking can be used to think about more sort of resilient healthcare systems in the light of our current context, which is the context of global pandemic. And I thank both of you for being able to talk with us. I know Joachim, you're in the deep night in Australia.
Yeah, it's 9 o'clock, not too bad.
Not bedtime yet. And thank you for all the participants. As you're signing on, I'm seeing you. And if you would like to just send us a message in your text box where you're from, what your field of specialist or interest is. I see there are some primary care healthcare workers signing on. Thank you very much for that. Just share that. And then just a household rule is you'll see that there's a question and answer box at the bottom of your screen. If you want to ask questions, we will have time for that. Please ask it there because everyone can then access it and they can even vote if they want to make it more important or want it answered more importantly than others. And don't post the questions in the chat box because not everyone can see it there. Right, let's start. I'm going to ask the two presenters to just introduce themselves and to just shortly so that we know where you are, what you're working with, and maybe then in the same time to just share with us how you came to engage in complexity thinking or systems thinking in your specific areas of specialization. Would you like to start, Joachim?
Yeah. Thanks, Rika, for putting this on. I am a semi-retired now general practitioner in Australia, and my main work currently relates to caring for people in a nursing home without COVID infection. So I don't have any complexity to deal with, but certainly there are lots of issues from a health systems perspective that are reflected in that micro environment of a nursing home. And coming back to your original question, how did I get interested? It goes back to probably the mid-1990s. I was interested in continuity of care, which was a big topic at the time. And the proposal I made is to view continuity of care, not as a phenomenon of two people meet in the practice, but that it is an integrated issue where two independent people come together in the consultation. There are dynamics of the consultation that lead to particular outcomes, whether they are sort of the health improvement, whether there are the coordination of care, the satisfaction of the consultation, and they create a feedback loop back to the patient and the doctor as individuals, but also have a feedback to the healthcare system as such. The problem was that the guy I wanted to do this research with then said, that can't be done. Research is done, you focus on one thing only. And I said, okay, thank you very much. That's not what I'm interested in. That has been done before. I don't believe that you can decontextualize the phenomenon by itself. And in the end, I just started to do the work myself. And if I go to screen share, you can see this was my very first complexity model, which was written up as a commentary, and in the end to just show the conceptual framework of a systemic approach to thinking about the care process as being dependent on your political and health system context, but also at a lower level between two people who interact and achieve something. And the next step came through my interest in what is health in itself. It became very clear to me that health in the end is not necessarily sufficiently described by the biopsychosocial model, because there's also, in my view, an important part which is called the sense-making or the cognitive or the semiotic domain. In my practice, I'd seen lots of people who were not ill in itself, but they couldn't understand what was going on, and their true need was to make sense out of what they experienced, with or without the presence of identifiable disease. And when I started to think more deeply and discussed it with colleagues, what we came up with is this model you see on the right-hand side, that essentially our health is always a little bit influenced by the somatic or physical domain, by our social connectedness, by our emotional connectedness and experiences, and then by our sense-making abilities. And there are...
Joachim, sorry to interrupt you, but your screen has frozen and people cannot see your slides. So, so maybe just either put on your just your picture, your frozen picture, but we can't see the slides or you. For most people, your picture is just black. I think it's because of the frozen.
Maybe I.
Sorry to interrupt, but
yeah, maybe I can't share my screen after all.
Maybe just talk and switch your profile to your picture, to your photo.
Okay. Sorry about that. We try to provide you with a bit of pictorial material to see what it all boils down to. Out of this came that you actually can identify that health and illness are dynamic processes, and these processes can be utilized in the consultation just by the awareness that it is not necessarily the face value complaint, it aches here, or I can't use part of my body in a particular way, that give you the answer to the problem. And the next step out of that was quite a big shift in collaboration with many other people coming from quite a variety of different fields that have led to the integration of health in the context of your external environment and your internal biology, showing that your health is largely dependent on your environment having an effect on your bodily function. So that particular work has given a scientific explanation to what has long been known at an epidemiological level, that socioeconomic characteristics are influencing your health. So that gives you a bit of a background of the humble beginnings of looking at a simple problem like continuity of care in a different light and taking it then into the conceptualization and the translation of the conceptualization of health as a multidimensional contextual phenomenon into clinical practice.
Thanks, Joachim. That's where the strength lies in the application of these ideas. And Bruno, you've been working for many years. Please introduce yourself and the way in which you're using them.
Yes. I'm Bruno Kissling, and I'm a family doctor in retirement now since 1 year in Bern, Switzerland. I was working for more than 30 years with patients, and Joachim and me, we are friends since maybe 20 years, and very different. He's very theoretical. He looks the things from an overview, and I'm really just a practical man. I'm not a researcher. And my interest to complexity came out from a personal experience in the midst of the 90s, when I experienced that I know a lot about medicine, but often I cannot help people. And this was very strong, and the whole confidentiality, the whole responsibility was on my shoulder. And then I heard about systemic solution-orientated medicine. I made courses, and this is quite a complex looking to the people, saying that their disease has to do with the system they live in, with interactions with this context and the environment. But I could not give the name complexity yet. Then in the beginning of 2000, 4 articles in BMJ about complexity were published. A few time later, WONCA Europe made a definition of family medicine, and then I learned why it does not function, because family medicine is the first contact place for all people with all diseases and unselected. And so symptom can mean a banal problem or can be a first sign of a dangerous disease like cancer, maybe an ache in the throat. And in the definition, it was very clear that the context rules plays a role, and that family medicine has an own epidemiology and own teaching and research agenda to find out what happens in this family medicine, in this complex family medicine field with a lot of uncertainties. And then in the same time, it came up with evidence-based medicine, guidelines, quality discourse. The doctors were no more a sign of quality by themselves. They had to prove quality. And they have also to prove that they have to visit courses about quality and about medicine. And so they came up the quality circles. We said, when we have to do continuous medical education, then I want to say how we do that. And we will make it from family doctors to family doctors. And these quality circles have been circles of peers. When we talked about, then everybody knew about we are talking because they had the same experience field. When we went to continuous educations from specialists, then it was very interesting, but we went home and we did not use it because we did not have the patients who match to this knowledge. And then in our quality circles, we choose the theme of a complexity. We wanted to show why we often do not have adherence to the guidelines made by specialists with groups of selected people. They do not meet the needs of our patients. And then we tried to make research on complexity. And we knew that with the quantitative research, we cannot find an answer. So we got in contact with anthropology, who was used to make a qualitative research. And from then, an anthropologist met our quality circle. And she made the thesis, and later on we wrote a book about, she and me, about quality in medicine. And another quality circle member said how we can see what the complex things they happen in the consultation. And she said it is possible with a film. And she came with a film team in the consultation, in living consultations, and for weeks with several doctors in Switzerland, they made a documentary about. This showed how quality comes up in this complex field of unselected patients. And so this was my way more from, I looked to the complexity from the practical part. Yeah, that's
great.
My way.
Great. So it's really from coming up with a frustration in your work that you saw that the models and the ideas that were I would say forming the rules and the regulations of your practice and your field wasn't at all engaging with this notion of what it means to be human in a complex way. And I think that's also what we are discovering in our work, is that people are actually realizing that their project management tools or their management tools or their governance tools or their measurement tools are actually there's usually a gap between what the tools can do and what they assume can be done, and the reality out there, in a sense, and that's when we realize that there's a kind of a gap, and that we start looking for models or ideas or words or ways of thinking that can actually address the realities as we are experiencing them. One thing that I've sort of just noticed by having been in conversations with some of you and with reading a little bit up on complexity in healthcare systems, and we'll come to this notion of COVID a little bit in the second half of our program. I think we just want to establish a kind of a basic understanding of what does complexity thinking or resilience even mean from a systems perspective more generally, and then we'll try and apply that in more detail in the second half of our webinar. But this notion of how we define disease and health and well-being, I think one gets a different understanding of that from a systems perspective. Would you both maybe just share with us? I mean, there's a lot of, on the one hand, there's this jargon that we have, emergence and self-organization and non-linearity and tipping points. That's the jargon of complexity, systems thinking. And on the other hand, you have your field where, you have to give definitions of what is disease or what is a consultation or what is health or healing. How do you bring these two things together? Is there a definition of disease or healing that's informed by systems thinking or the words in complexity? And how do you bring that together?
Well, one of the problems is that words have shifted in their meaning. If you say the word disease in its real way, it actually sounds dis-ease. So we are talking really about the complex experience of not being right. And that can be caused by all kinds of things. What drove it home to me was very early on in my practice, where I saw a 20-odd-year-old young girl dying from cancer. And the week before she died, she asked me, "Doctor, I know I'm dying, but can you explain to me why I'm feeling so healthy?" So even in the most adverse stage of your life experience, you can feel healthy, even though you are affected by the object of what we are dealing with, diseases. And the disease itself has not necessarily the expected impact that we normally are socialized with. You go to the doctors if you have a disease. And it is really interesting that if you see health, illness, and dis-ease as 3 points on a subjective scale of experience, you can contrast that to the objective findings that medical professionals or health professionals at large are indoctrinated on the much more reductionist notion of the object of disease. That what can be seen under the microscope or on an X-ray is what doctors are trained in, or health professionals are trained in. And it relates back to Bruno's experience that most of the time in family medicine general practice, people are not coming for their objective part of their health experience. They come because they need care of explaining and exploring their understanding and contextualizing their experiences in their own context. And it may at times be rather difficult and challenging and frightening for health professionals to be confronted with something that has been neglected in our education as health professionals. And I don't see that particularly as a doctor problem. That affects all health professionals equally. So to me, the language of complexity is much less important, whether you understand the concepts of what is emergent or what is a tipping point. It's much more important to go back to very simple basic principles. Nothing occurs by itself. Every change is affecting everything else you can think of, and you cannot do a good job in the health professions without taking that into account. And I go a step further. I think that applies to all domains of life, whether you look at it at family life, or whether you look at it in working life, whether you see it in politics. It is a matter of not believing that there is a quick fix for a problem. And with that, we could go into COVID. But I would like Bruno to have a chance to share his ideas.
Yes. Again, dear Joachim, you looked at things from the theory, and I maybe can bring in now the practical way. And the complex adaptive systems and solution-orientated thinking, which comes from the psychology, has a lot to do. And I can tell how I do this in the practice to bring all these very important things for health and disease on the table, and to discuss it with the patient and to bring it in as part of therapy. As Joachim told, the disease is the diagnosticable thing, technical thing, and the illness is how a person experiences this disease. There are a lot of people, they have no diagnosticable disease, but they are ill. And they are very ill, very diseased people, like the example of the young woman with cancer, and they do not feel ill. What happens? And from the patient's view, a symptom he feels or a problem he has is always interdependent with his environment, with his social and professional and natural environment. And with his symptom, which he expresses, he influences the environment, the context, social context. And there happens a reaction on it. And this reaction influences again the feeling of the patient. And this can go in direction of a disease, of an illness also, or can balance it again. And if a people comes to the doctor with an illness, maybe it's not only himself or herself who has the disease, but the system is disbalanced. And on this person, the disease comes out. And you cannot just heal the disease without influencing the system where he lives it, and to find a new balance. But how to do it on the patient-doctor's part? In systemic solution-orientated medicine, we look at the consultation as a meeting of experts. The patient being the expert of the illness, how he experiences, what he feels, and the doctor as expert of the disease, the medical part, and the biopsychosocial part. And they, in a mutual respect and relation and trust and empathy, we discuss together with active listening and asking the right questions. I can involve the patient not only because of his symptom, but also with his context. Then I ask him, what are your ideas about the symptom? What are your fears, your concerns, and your expectations to me? What does your wife say to your symptoms when you complain about it? What does your colleagues in the profession works with whom you work in the profession, what does he say? What does it make with you when he tells this? What is positive when you have the symptom? What do you not have to do? And what should you mean of this symptom when you are healed? What is helpful of it? And we ask many questions, not only when do you feel the back pain, how long do you feel it, what does it do to your legs or something, irradiations, but we ask all these contextual things. And reflecting on these complex contextual things, this shows ways how to find solutions. I will inform the patient about medical possibilities and non-medical possibilities, and then we will find a shared decision in shared responsibility. Here in the responsibility for his context, and me in responsibility for the medical part. And so we will find out that a lot of uncertainties are there. There's uncertainty about the diagnosis, uncertainty about the examinations, uncertainty about the effect of the therapy. And together we discuss about these uncertainties, and we will decide within this uncertainty what next step we want to do, and how we will control if these steps is a good step or a bad step, and what we will do afterwards. And so we can, in this complex interaction, we can find out the complex interactions of the patient with his context. And we can find solutions. And this will not be the solutions which I would find out as a doctor, as a medical doctor. There are solutions, they are involved and has to do with the context. And so the consultation gets an instrument like the surgeon's knife, but a soft knife, an instrument who will bring the patient in a healing process, maybe not to health, but in a healing process, in a way, in direction to health, to healthy feeling, to well-being. So that's what I can say from the practical part about.
I think the point you are making about feeling healthy or making healthy again is really an important part. The word health means actually nothing else but feeling whole or being whole. So the task is not to eradicate something that is with you. It is more a question of integrating it into your whole. I guess one of the things that occurred to me while you were talking is that we really need to see that, at least from a primary care perspective, we have an important social role to play. And that goes back to Rudolf Virchow, who said medicine is nothing else but politics at large. We have a social responsibility to improve the environment in which people get ill and develop diseases. And I think that's then sort of a step up in complexity onto a broader level. What I find is very interesting in this discussion, that we are seeing the complexities within one level, but also creating complexities across the levels of scale.
So, Joachim, medicine is a medical and also a social work.
Yes, completely agree.
The medicine today has a very huge technical approach, and it goes more and more to personalized medicine, bringing the right medication to the right patient. But what we mean is that we must include also the humanity part, the personal part, the social part, to bring together with this medical technology to have a good instrument to make people healthy again in a huge sense.
These things are not mutually exclusive. If you think about it in terms everything is connected with everything else. While I guess you and I are both critical about the way medicine is currently practiced, it is not a denial at any scale that the part that we have been trained at our student times and then seen in practice has nothing to offer, but it has only something more limited to offer for the patients for whom these type of interventions truly make a difference. And not all that is done in the health professions actually has a benefit to people, and we need to bring that to the forefront and discuss that. Overdiagnosis is now probably a greater health risk than anything else.
Yes, and in this technical part, we make always more and more from the same, more and more techniques, more examinations, more and better examinations, but all these have risks. And in the end, these overdiagnosis and overtreatments, over-examinations, to find out what the disease is, brings the patient in danger and makes the costs no more to pay.
Yeah. Thank you. I think that was kind of a deep discussion in the sense that what we are scratching on here is the surface of, of what we are seeing is coming apart at the moment. And if we look at, how ill-equipped, in a sense, health systems are to to deal with capacity and scale when things get scaled up in a sense. But before we go to kind of a COVID discussion, I just want to summarize what I've heard from you both, just to maybe generalize that then also to the larger audience. Because when we are listening from a complexity perspective, we are always trying to see what are sort of general applicable approaches for trying to intervene in complex systems. And what I've heard so far by just listening from the two of you and your expertise in the healthcare system is that I've heard that context matters, and that context actually not just only matters, but that it actually brings about certain things. And how do we start dealing with context, not as something that's in the background, but actually something that's really constituting things. I've heard that giving people shared agency is important. It's not just the doctor in the white coat that we follow yes and no, and we become blind followers. So how can we translate that into any kind of decision-making process, so that both, that the power is shared between people are giving both people agency. I've heard the importance of active listening, which is kind of listening, which is more than just listening for what is said, but also listening for that which is not said, and to try and engage with that as a full person. The notion of trust comes out, and that always surprises me how important trust is in all of this. A reframing of what we understand things are, a reframing of what is health, what is illness, what is disease, a reframing of what is the role of what it is that we do, which is important. Shared decision making, having shared responsibility. Often we believe that the health system or that health experts should have all the expertise and answers to everything that we need. And, as patients, we often don't get given responsibility. Accepting uncertainty. And I think, or not accepting uncertainty, but understanding that things are, that there aren't quick fixes to these kinds of things, and a total reframing of that. So thank you very much for sharing that. I think what if we may move our discussion a little bit to trying to see how this way of thinking and your deep experience of practicing in the healthcare in relation to the pandemic that we are facing. What are the obvious or even profound or wow moments that you've had since the beginning of the pandemic, and how has this systems thinking and complexity, the understanding of complexity, helped you or make sense of what's happening, or given you some form of way to critique what's happening at the moment?
Do you want to start, Bruno?
Joachim, start you again so I can rest a bit my tongue.
Well, I think COVID is a horrifying example of simplification. If you look at some of the basic facts that have emerged, when it all started, we had very little knowledge, but there's more and more coming out. And one of the things that has become clear is that lots of people get in contact with this particular mutation of an otherwise common virus giving you cold symptoms that have no symptoms, no signs whatsoever. There, of the ones that have a positive diagnosis and have some symptoms, most of them are rather mild. And there is a small group that gets very severely ill and has very poor health outcomes. But if you look at that, then you see that there's a patterned outcome. You have, and this pattern follows a Pareto distribution of the 80-20 split, more or less. If you then look at for whom does this mutation make a real difference, you end up seeing that it is the elderly who are usually defined as frail, meaning their resilience to any kind of disturbance to their systems becomes very limited. And then what it has emerged too is that it is a disease of poverty. If you think about New York, the stratification of disease occurrence and mortality follows the social gradient. If you live in the Bronx, you do very badly. If you live on Staten Island, you have virtually no problems. If you live in very dense and overcrowded situations, you do very badly. And it now has emerged that probably health professionals, young healthy professionals who die from the disease, die because of an overload of viral exposure, rather than that the virus in its normal environment would have caused any problems. Take that for what it's worth and compare that to what you hear in the press. It drives me bananas that everyone only counts people identified with the disease and counts the numbers of people who die without providing any context. On the one level, what is the denominator? Meaning how many people get diagnosed with the disease within a particular population, and also who dies. What is the denominator there? Is it the whole of the population? Is it people who had a positive test? Is it people of a particular age group? All of these things provide you much more information than just the meaningless counting of numbers. And it I think highlights how little the political and the health political processes are actually engaged in context and in trying to understand the multiple interacting factors that are associated with this pandemic. If you don't do that, then we'll see sort of what we see. Knee-jerk reactions, you close everything down where it doesn't make any difference to most of us, and it may not even be of a benefit to those who are at highest risk, because if people don't get immunity the natural way, and the vaccine is not there to arrive very soon, as soon as you stop all the social distancing measures in whatever form, more people will get in contact with the virus, which spreads initially unnoticed, and the people that we want to protect are the ones that we put at greatest risk. So I find it very disturbing that none of these people either have the knowledge about systems and complexity dynamics, or people who do have understanding are not either asked or listened to if they say something. That's my gripe.
What can I add here? I think it is a masterpiece of uncertainty. And all the reactions are at the edge of the chaos. I find that some simple rules seem to help to downgrade the numbers of sick persons. And these are the distance, 2 meters, hand washing, group sizes, and this seems to be helpful. Seems to be helpful, Joachim. Seems to be helpful. But in the same time, you see the interdependence of all. If you make an approach to save the capabilities of the hospitals and to downgrade the number of sick people, then you influence the economy you influence the sociality. And if you influence the economy, it is not just the economy of the richest, because they cannot get more rich, because it is also a downgrade of the workers. They have no work, no income, no money, and poor health again, and more susceptible for the disease. It's a catastrophic downgrading. And this interdependence is very, very interesting. And I ask myself if we learn for future events like this. I am not sure about, but uncertainty has always the part not only of fear, but also of hope. And so I hope that out of this, of all this, we can learn more about and to be prepared of a next pandemic or a next catastrophe, like the environment catastrophe. This is what I think about, and I would not be a politician today and decide on this uncertainty, on this small data, on the wrong data. I admire them to do something, and they had to do something. I think they could not just wait. Everybody who said, "Oh, let's wait for herd immunity," they changed after a few days, because they cannot allow themselves to do other things than to follow the herd of politicians who decided to do this. It is something where we only can make mistakes. And so I'm very happy to be a doctor today and not a politician. Yeah.
There is an issue that uncertainty requires communication, and from a trust perspective, you become less trustworthy if you are not acknowledged there's uncertainty and describe what the uncertainties are. In the end, and then there we come back to some technical terms like emergence. This is an emergent situation. It is developing, and we only can understand what is happening now in retrospect, after it is all over and done with. In emergent processes, you need to be very clear about what are the things that we know, what are the things we don't know, and describe. And you don't have to do that in technical terms, but describe in as an outline what are potential different outcomes that can happen if we go along line A, B, C, or D. And if you then have outlined that, I think by saying, given what we know, let's go path A, and be prepared after a week, after 2 weeks, to revise your strategy if path A is not getting you where you want to be. But you need to be open and transparent, and this is certainly one of the things that is lacking in the process. That politicians have an issue, that they're torn between the economy, between the people's desire to receive health care if they fall ill, that they have an imperative not to overload a failing health system in terms of financing structure, resources, is another dimension. But you cannot manage a situation like COVID by not outlining the different dimensions and the interconnections that are there. The greatest catastrophe, in my view, is not the people who unfortunately succumb to the disease. It's not even that we end up in a recession. I think the greatest tragedy will be the degradation of health for a whole generation to come down the track. The real health consequences of this can only be envisioned the level of lasting psychological distress, seeing more PTSD, post-traumatic stress disorder type symptomatology, that will last for the next 20 or 30 years. You don't know the epigenetic effects that a crisis like that has. We know that kids born to fathers who, before they went to war and after they went to war, have a completely different psychological experience and life expectancy. So these are the things that we need to tackle, and we need to tackle them now. It's no good, like all mental health experts say, there's already a rise in suicides, and for Australia, they reckon there might be an increase of about 30% to the baseline rate for the next 5 years to come. So, to me, this crisis shows how our system as a whole is really not run as a system. It's run as silos with vested interests, where who cries wolf the loudest will get most of what you can get. But it's not really making the system sustainable and from a health perspective allowing best possible health to emerge for everyone in the community.
You told about trust, and trust is lacking at any part. The numbers, they have been collected very differently, and nobody trusts to the numbers of the other. And also the trust to get the safety items in this global commerce, the trust was not there. Everybody had to look for themselves, and it was a panic reaction in all directions a little bit. And what you say is so important, that this could be the agenda for preparing the next pandemic, which will anyway will come. Everybody has been overwhelmed, but I think your agenda should be inscribed in all heads of politicians to sit together and to decide how to make the decision way for the next time.
Well, I think that one needs to take it even one step further. This is not only about pandemic, that's about any other disaster that is coming. As an Australian, we are living in a high-stress environment since about August last year, when the first bushfire started very much earlier than normal. When the bushfires finished, we had floods. And the floods were not really over when COVID became the next big thing. Australia, from my perspective, is exceedingly underprepared at all levels of the scale to deal with disasters of any kind. Unfortunately, we have such a strongly neoliberal-oriented government. They're now already talking that getting us out of COVID will be the responsibility of the market. But the market has been one of the main reasons to get us into this untenable position is not entertained. These guys simply do not have the capacity to understand that things are interconnected, and they certainly have even less ability to anticipate what kind of consequences that may have. And in one way, I can excuse them. Dörner has written a book in the 80s where he examined how people make decisions. And the book is called The Logic of Failure. It's just humans are not very good at analyzing interconnected phenomena, and they're even worse in anticipating what will happen more than a couple of steps ahead. And it really didn't matter whether they asked experts in a problem or just took someone from the street and says, here's a problem. Everyone did poorly, with a few exceptions. And the few exceptions is you need to take your time to try and understand the problem. If you think you have something you can hang it on, don't respond in a massive way to that particular part of the problem. If you do, you will always get an overreaction, which leads then to another knee-jerk response in the opposite direction, and you just make the problem worse. You don't bring it under control. What successful people do in complex situations is minor tweaking of a particular thing that they feel can be changed, and give it enough time to see how it pans out. And you then need only a few small adjustments to get the whole of the problem, or the whole of the system that created the problem, into a state that is more manageable. So in that way, I think complexity also tells us that we need to really work hard with ourselves to overcome, or maybe biological given limitations that when we were still living under the sky, you needed to be quickly making a decision, and if not, I always say it that way, you became a cat's breakfast. You needed to be able to run away. And if the only response is if there's a problem, you run away, that under particular circumstances might be a good idea. But times have changed. Running away is not a solution to solve COVID or to solve many other problems we are confronted with.
Joachim, do you have an idea how to make this change in the thinking with the politicians who decide all these things, how to bring them together to in a catastrophe to be calm and think about before doing the first small step? Do you have an idea how to do this?
Well, this is probably where I end up on my hopelessness and where rather become the glass half empty rather than remaining my glass half full perspective. I think that one needs to say that the politicians we have are all of a mode that is not exhibiting the key features required for system thinking and approaches. I think in my hope, I've written a book on health system redesign, as you know, which provides a blueprint for how to go about it if we reach a point where a discussion about these things is possible at a global way. I was very disappointed. I tried to get more enlightened journalists to take it up, but they say no one will read this. People are not interested, which may well be true. I have to say I find it rather disappointing, and maybe I have to accept that most people are just more by necessity of their lives, struggling with making today work rather than having the capacity on Maslow's scale. If you function at the very bottom, there's nothing left to deal with higher level needs and aspirations. I very clearly see it as an issue of society needing to start a discourse, and we need leadership to do that. but I don't see anyone around, and I don't think they take me seriously enough to make inroads into that.
Thank you. I'm just keeping an eye on the clock, and I know that many people have Zoom meetings hour after hour booked in this new world. And I'd like to thank you both very much for your deep insights in working in this field and also pioneering the field of systems thinking and complexity thinking in the healthcare world. One last, if I might just ask, one last short half a minute word of hope from each of you for people going away and in their daily lives, to just maybe conclude our session. Give one of you just, or both of you, just a short last word to leave us with and to take us into the rest of the week.
I think you are the mob that needs to join up with other people around the world who are interested in getting systems and complexity sciences into the forefront of doing things. And Rita can pass on some more details about how to potentially do that.
Yeah. Great. Thanks, Joachim.
Did not understand your question, I think.
Just a last word from your side, maybe one word of advice or hope that you would want to leave the discussants with.
I think in the middle of complexity is the uncertainty. Uncertainty who interwaves all things, and which is needed cannot be eliminated, but it is to cope with uncertainty is needed for the change, and uncertainty in the end is life. Every step we do, if we walk, we must lift one leg, we go out of balance, but we have to trust that the other leg will keep the balance again. And so uncertainty is something very important, and to cope with it, to be aware of it, and to love it is maybe a very important thing.
Thank you very much. Thank you so much for your time and for sharing it with us. And I will, if there's any questions that come up, please send it to me via email or in your response to this meeting. And we will post a recording of this meeting on the CST's website. It will be available within a week's time or so. Thank you very much. And then next Thursday, we'll have another session at 12 o'clock, at 1 o'clock, in Cape Town time. In Thursday, 1 o'clock is our webinar meetings for those of you listening or who joined us to share again. Thank you so much, with much appreciation.
Okay. Bye.
Thank you, my pleasure.
Bye, everybody. Thank you very much for attending.
Bye-bye.
Bye.